Hello everyone and welcome to our professional development session on behalf of Ealthy today. My name is Bethan Edwards and I'm here to introduce our really great speaker for today. Just before we start, a little bit of housekeeping. Throughout the session, we'll be keeping an eye on the chat. So if you have any questions or technical queries, please just put this into the chat box. At the end of the session, there'll be time for questions and answers. So if you have a question about what's the topic today, please put your question into the Q&A button on Zoom, which you should be able to see on your Zoom toolbar. The session is being recorded today, and this will be available for Ealthy members on the members section of the website after a period of time. All right, so I am going to introduce our speaker today. So we're really excited to have Dr. Emma Brooks from Birkbeck and University of London. And Emma is a lecturer in applied linguistics, and today she's going to talk to us about multilingualism in healthcare, specifically talking about maternity professionals. So over to you, Emma.
Many thanks, Beth, and thank you so much for inviting me to talk to members today. So yes, first of all, I'd like to start off by saying the information and the content today has kind of been accumulated over a couple of years of research, and the majority of the data I'm going to be sharing with you today was in fact funded by an impact grant from UCL where I was previously affiliated. So, but I'm now currently at Birkbeck. Okay, so in today's session, I can work out how to change my slides. Okay, bear with me a second. Okay. I'm going to kind of start with a bit of an overview of how my research evolved over a period of time, share some observations from field work that I've done and observations of consultations. And then the main body of this presentation will be looking at the experiences of multilingual healthcare professionals whom I interviewed. So, okay, so I was an ESOL tutor for approximately 15 years, and I started a very small scale project when I was doing my master's on the experiences of some of my students when they had babies in the UK. It was very interesting. I found that women had a lot of experience of objectification and very unpleasant birthing experiences. But weirdly, although, as you can see from this quote, they had some, pretty traumatic things happen to them, they absolutely loved their midwives. And I was thinking, this is so interesting. So on one hand, you had a really poor experience, but on the other hand, there was a great deal of respect and admiration for midwives. So I thought, what's actually going on in consultations? So I managed to get some funding for my doctorate. The possibility of being able to go and see observations, consultations as they took place. And I actually observed medical professionals engaging with women who were pregnant in antenatal clinics. Now, there's a lot been written about intercultural health communication, whether it be on power dynamics or on the potential for misunderstandings, the position of interpreters, whether they contribute to consultations in a positive way, as well as they contribute to consultations in a potentially not such a positive way. And also there've been recordings of people, having interlingual consultations with health professionals in a European context. And I really wondered what it was like in the UK. So, whoops, okay, speeding ahead of myself there. So my research was a linguistic ethnography. So it meant I spent a long period of time, actually over 6 months, visiting an antenatal clinic in London where there was a minority-majority borough. So there were more minorities in this borough than there were in perhaps rural England, for example, where they were the predominant population were perceived of as being minority. But there was, and although we knew that there were over 100 languages spoken in this borough, there wasn't anything that could really enumerate the languages or connect them in any way to people's ethnic identity. Because I think this is a real problem with some of the data that we look at when we look at health communication and health inequalities, is the fact that language and culture and nationality and ethnicity are often really lumped together in quite a problematic way. But anyway, so I went into this hospital and I was able to watch 11 consultations, and I interviewed different interpreters and midwives themselves and made field notes. Okay, so what did I find? Well, I found that there was a lot of mediation between health professionals and their patients. Now, when I was asking for wanting to achieve consent to actually go into consultations and reserve them, I needed to approach midwives and other health professionals, so that goes from consultants right through to healthcare assistants, to get their permission, but also to get the permission of the woman or her interpreter and or whoever may be accompanying to her appointment. And what I found extraordinary is, in fact, although my only stipulation was that women were had limited English proficiency as assessed by the midwife or as self-assessed, asking for an interpreter, actually it turned out that every single health professional they saw, bar one, was in fact an international health worker themselves. And sometimes they shared the same languages as the patient, and woman, because she was actually pregnant, it's not a disease or an illness. They shared the same language. Sometimes they shared a lingua franca, and sometimes there were conversations which involved, interpreters and members of their families, members of the woman's family. A lot of mediation over understanding, kind of epistemic flattening, so the health professional trying to make something quite complex easily understandable to the woman that they were talking to, and there was some mitigation, like hedging of complex things. So, for example, we're talking about really personal gynecological details. There was often quite a lot of use of idiomatic language, which I think we've seen before in the literature, which wasn't necessarily always very helpful. But even within that, there was a great deal of effort that went in by the health professionals to try and make themselves as comprehensible as possible to the women they were talking to. It certainly appeared that way. There was also quite a lot of creativity, so people drawing pictures, a lot of miming. What does a blood clot look like? It looks like this in your blood. Again, not necessarily always entirely clear, but there were the efforts there. And there was also a huge amount of humour in the consultations. So there was kind of, oh, we're not really understanding this kind of humour, but also making jokes with women as well. I'm just going to share two examples, which I think kind of cover a lot of these findings. So you can see what this dialogue really looked like in person. Okay, so in this example, the midwife is talking to a woman who's coming to have an anti-EG injection, which is she has the potential for her next pregnancy, different blood condition, which potentially can cause difficulties in her next pregnancy. So to prevent the kind of rejection of the fetus in the next pregnancy, it's important to have an injection during this pregnancy. So the midwife has established that the woman doesn't speak any English. She's originally from Portugal. The midwife is originally from Italy. And the midwife decides to use Spanish as a lingua franca, because having given the woman, all the information that she needs prior to having this injection and to engage and get her consent, the midwife then decides to reiterate it in Spanish, and uses a paper towel that they have handy to kind of draw a picture of a blood cell. Now, it's a pretty complex thing that they're trying to explain. So, we could argue, of course, this is not necessarily hugely helpful, but in fact, it shows the extent to which the midwife is attempting to communicate things in a comprehensible way. And I'll come back to this example later on. The next example I'm sharing with you is a woman who attends the appointment with her partner, and the woman has gestational diabetes. She's quite late into her pregnancy and her blood sugar levels are getting higher and higher. And the consultant is actually a bit concerned about this because the bigger the baby, the more potential difficulties there can be in delivery. It may in fact end up going to cesarean, which then gives a higher risk of potential consequences. So the intention is to keep the woman's blood sugar down, and the consultant, this is part of a consultation with the consultant, is giving advice over food and exercise. So she starts by saying, well, what did you eat for dinner? And the interpreter chips in, here to translate, what did you eat for dinner? The woman wants to clarify, what, yesterday? And the husband fills in the details. Oh, we had idiyapping. Okay. But the consultant then joins in the consultation by saying, roughly like every day. So then she's looking for habits here, looking for habits, and she can understand the Tamil. And then the interpreter again clarifies with, usually, what do you eat? So there's a lot of teamwork going on here to clarify. We're looking for habits. We're not looking for one incidence. We're looking for, what do you normally eat? Because, gestational diabetes is about amending, long, established eating patterns and perhaps adapting if necessary. This interpreter was from India. Sorry, not this interpreter. This consultant was from India. And I went on to see this consultant speaking over 5 different languages to different patients. She was incredibly skilled multilingually. Although she didn't have the ability to speak Tamil, we learned later on that actually she has very good receptive skills and she understands it, which was why she was able to listen to this conversation, say, actually, we haven't quite got the exact meaning of what I want. I'm looking for habits, not, not just one-off incidences. And also what we can see here is part of this kind of building a relationship. So the consultant demonstrates her kind of her competence, her cultural competence, I guess. Did you have any putu? And she said, oh, no, because she knows this is not perhaps it's a dish which is quite rich, quite high in sugars, and probably not something she should be eating. So the woman says, no, I didn't eat this. And the consultant laughs. And the woman says, no, I haven't had any for 2 or 3 weeks. I haven't had any putu. So the consultant again is laughing with her. She says, no putu, no idli, no dosa. And laughing, joking and teasing her, but also hoping to kind of clarify that, you shouldn't really be eating these foods, but it's done in a very non-threatening way. So I really found this fascinating, this kind of, the ability to draw on these multilingual repertoires to kind of understand a little bit more clearly what was going on with interpreters, to kind of check that the interpreter was interpreting accurately, or to get the kind of, the meaning that led, was underneath the questioning that the consultant was looking for. Of course, where I saw these very positive things, there were examples of misunderstanding, and not necessarily between the multilingual health professionals and the women they were working with, but more with the interpreters. And this is a sort of an issue of health literacy that really raised its head. How much did the interpreters understand of what they were being asked to interpret? This is probably for another talk, but it still existed. Okay, so we can work on the kind of Roberts and Sarangi's work. We can see, and Moss, we can see from those consultations in the GP practices in 2005, misunderstanding was a big element of that communicative episode. And still, obviously these things still exist. They don't just disappear with time, and interpreters have different training. And there are also issues of power, I think, at play here, because, who decides when they can use an additional language? How proficient do they have to be to use that language? How much of that language is shared? If we think about that lingua franca episode with the Italian and Portuguese interactants using Spanish as a lingua franca, how helpful was that? Are they always mutually comprehensible? We could ask why the midwife in question did not try to contact a Portuguese interpreter at the time the woman presented, and it became very clear that she didn't speak any English. So there are dynamics there which certainly still exist. Anyway, I still thought it would be really interesting to talk to the multilingual health professionals, because how did they know when to use different languages? Were they allowed to use different languages? What was the guidance on this? And so, and one of them said something to me. I'll come on to who I interviewed in a minute, but one of the things that really struck a bell with me was the fact, she says, well, we always think everyone is just British, and we always assume that we are a homogenous population and that everyone speaks just one language, because we centralize ourselves. It's that kind of English monolingual habitus that we have. We assume that everyone will speak English. But it's not necessarily true. And it's not necessarily very helpful to think of the UK or certain parts of the UK as entirely monolingual. In fact, if we look at literature on superdiversity, for example, we can see that, the populations are changing. It's very ironic that I'm giving this talk today on the day that the migration figures came out. And I was just saying to Bethany before this started, I was desperately trying to find a breakdown of how many international medical professionals, had moved to the UK in the last year, but that kind of detail's not there yet. Perhaps that will transpire in the next few days. So if we look at data from last year, the House of Commons data says that 20% of staff were born outside the UK, NHS staff, I should say, in this context. And that in 2021, just over 50% were midwives who joined the NHS trained overseas. And when we look at doctors, that 50% of new medical graduates who registered with the GMC also qualified outside the UK or in the EA or the EEA. So we can see that just as we see a diversification of the general population, we also see that represented across the workforce. And here, for example, one of the health professionals I spoke to said, well, look, we collect doctors in little groups in the same way that you collect, patients in little groups. So there are more Italian doctors and Greek doctors here than on average in the NHS, in her specific area, in the way that there are more patients who are Greek or Italian. So you start seeing a reflection of, the diverse population within the workforce. Now, they may not all be doctors and nurses and medical professionals. As we see, 20% of staff are born outside the UK. But again, what does this mean? If someone's born outside the UK, they could still be a first language speaker of English. And just because somebody is British does not mean they're not multilingual. So what does this actually look like in practice? Who are these people who are drawing on their linguistic repertoires when they meet women? Okay, so what I did was using networks that I had, I managed to contact 11 maternity professionals who were very happy to take part in this inquiry. They worked at 9 different trusts, and they were from every kind of represented every area of maternity care, because I still wanted to say maternity care and kind of followed that right through from the patient's experience of giving birth in the UK through to looking at what happens in antenatal clinics. And, it seems sensible really to be looking at the same area. And I think the interesting thing about maternity care is that because it's a more holistic treatment than perhaps when you're being treated for a disease or an illness where you're looking at specific symptoms and you're hoping to cure somebody of whatever that problem is. When it comes to maternity care, you're looking at the whole person, their unborn child, you're looking at different aspects of their life and the way that those are affecting their pregnancy. And I think maternity consultations give an opportunity to have much more socially motivated conversations than perhaps other appointments really have got the time for or have the capacity for. I know that's a big generalization, but I hope that kind of makes sense. So I spoke to student midwives, midwives with a couple of years experience, midwives with extensive experience, consultant obstetricians and gynecologists, people who were working and teaching midwives, and also international recruiters, so people who are working with the NHS and recruiting externally from the UK. And the only prerequisite for taking part in this research was that these individuals drew on other languages other than English in the consulting room. I've just realised I probably should have included another slide about which languages were used, but from these people I can tell you that we saw that there were people who spoke Urdu, Hindi, Spanish, Italian, French, Russian, Cantonese, Mandarin, at least. And in fact, that's a good hint to myself. Put that on the slide next time. I'm sorry. But hopefully, as you read some of the quotes, you'll be able to see the languages represented. Okay, so what advantages did they believe came from working languages other than English? Or why did they use them? And similar to the kind of quite small literature at the moment on looking at multilingual health professionals, working in a diverse environment, they universally believe that using a familiar language for the patient not only improved the sense of the woman's sense of well-being and comfort, and enabled a relationship of trust to be built, but it also improved people's understanding. And when they understood exactly what was being asked of them, perhaps in a dietary way, or to attend certain appointments at specific times, or to keep an eye out for specific symptoms, that improved comprehension, these professionals believed improved their experience for sure, but also outcomes. And they also really felt quite appreciated by their colleagues and related being asked to come into appointments, to support a woman who had presented without an interpreter, but who needed support with part of the consultation. And they also realised that, the colleagues also saw that there were benefits to women having interpreter, a member of staff interpreting. So this was a quote by one of the midwives, who said that actually being multilingual was a kind of specialism that you're able to offer to people you're working with and that you're caring for, just in terms of trust and relationship building. Because often in maternity, you're meeting someone and suddenly you're with them for the most intense, frightening, exciting roller coaster. And therefore speaking the same language or sharing a language with somebody enabled that relationship to be much stronger, and experience and outcomes to be improved. Also, they felt a sense of pride. And this was a really fascinating observation from a student midwife, or someone who just completed her training. I was the midwife looking after a woman. The senior registrar also spoke Cantonese. The midwife coordinator also speaks Cantonese, and she went for a C-section. And the anaesthetist also spoke Cantonese. It was like the universe aligned, and it just so happened that the day you were admitted to hospital, and it was an emergency, everyone on the unit speaks your language. Honestly, I don't think I'll ever forget that shift, where I thought it's like we were all here for this woman at this, particularly in this example, I think at a particularly traumatic emergency admission. Several people spoke about the relief that women felt when they shared a language with her. So, for example, this midwife notes that I started to speak to them Urdu, and honestly, you can just see in their face that relief that they can express themselves to somebody without having to think about what to say. There was that connection straight away. And also it enables people to ask questions because, we all have questions when we go to see a health professional, and without the linguistic repertoire to be able to necessarily express ourselves, especially when you think about when we teach English as additional language, there is certain vocabulary that you just never touch in a classroom. You don't talk about uterus, you don't talk about ovaries, you don't talk about cervixes. So, when people are wanting to understand, they need to be able to ask questions. Exactly what does that mean? Can you give me that word? Is there an equivalent word in our shared language to be able to understand? all parts of their care. And midwives also talked about the cultural aspect, saying, you know, because I'm coming from the outside, I'm not born in the UK, and they're coming from outside, I'm a sort of bridge between the home medicine, which both are more familiar with, and the home medicine in obstetrics and gynecology, and the British one, and so they trust me. So again, being able to ask questions and clarify is something that you know, shared language can do. However, they did express linguistic reservations. Okay, so this very experienced maternity health professional said, I'm good at French, I'm good at maternity. Could I translate a liver transplant? Maybe not. There's a limit to how far you could stretch. Okay, so there's a recognition that, you know, your linguistic skills do have a limit, because again, a liver transplant would have a lot of complex, unfamiliar vocabulary, I guess, to the health professional as well, or familiar but not as familiar. So, you know, should I always use this language? Are there limits to when I can or can't? Another one said, you know, I trained in Italy, and when I come to talk to Italian colleagues, I can't remember the vocabulary because I've only worked in the UK in this, or I've worked in the UK for such a long period of time that I can no longer remember the equivalent vocabulary in Italian. So they said, you know, this is really interesting. Could I go back and practice in Italy? Maybe need to do some kind of refresher course, certainly on vocabulary. I don't know. Okay, and this contributor had a really interesting insight. She was multilingual. She speaks 3 or 4 different languages, South Asian languages, including very minority dialects. But she's learned them in the UK, so she's British. And I think this represents a lot of our NHS population. So on paper, she's British, okay? But she also has this really rich cultural and linguistic heritage, which she's able to draw on. But, you know, I learned my Hindi very conversationally. We don't talk about vaginas. We don't talk about that stuff. So I've had to learn. And sometimes actually being able to do a direct one-to-one translation is quite hard because perhaps there is, you know, just different vocabulary. So this also posed the question of, well, you know, when can we use our languages? When are we allowed to? When should we use those repertoires that we have, that we carry with us? Because it's certain that it's a valuable resource. But this is a senior medical professional saying, look, one of the issues I have in the antenatal clinic where I work, well, one of the healthcare assistants speaks Polish really well, very well. Literally every day she gets called at least twice a day to interpret. I got so upset, like we're running a service. You know, she can't just be pulled away every time. They literally don't even ask me. They just come and get her. Also, this is taking her away, or taking it away, her away, from the care she's delivering to the antenatal women. So there is a kind of invisibilization of this labor as well. You know, not only does this take the individual away from their work, which may cause problems for them, but it is constant. Okay, so it is a valuable resource, and it's obviously recognised by colleagues. But you know, how much is it seen? How much do we know? How many people have these resources? Who uses them and when? And is it allowed? Well, current NHS guidance is a little bit ambiguous, saying that, well, people can use additional languages to make appointments and for small talk. This is from the 2018 NHS guidance on interpreting and translation, and that they can only use a language to communicate with a patient or a pregnant woman if they're proficient in that language. But what is proficiency? And, you know, is it self-assessed? Is it something that's accredited? These are questions that would be really interesting to get your ideas about at the end of the session. Okay, so this visible/invisible resource was problematized by some of the participants. One Tanya speaker said, you know, she's just targeting someone because she's Italian, she needs to look after them. But sometimes they're not looking at the case and what my expertise is. Maybe my expertise is not right. Just because I'm an Italian speaker and the woman is an Italian speaker, it doesn't mean that necessarily I'm going to be able to enhance care for this woman. You're just targeting me because I'm Italian, and you're taking me away from perhaps an area of expertise which I can really make a difference in. Some people pointed to the lack of financial compensation. Okay, so you don't get an uplift on your salary because you can default to another language, and it's invisible. And someone says, sometimes I'm not okay with this. I feel like I'm being used, and not gaining any kind of formal recognition for the work that I do on top of my my normal routine job. And then someone said, well, actually, it's great that people are interpreting and it's really kind of them that they can help out. But I worry about it coming back to bite them. How much are we covered legally if something goes wrong? And this, again, is an issue that would be really good to get people's response on, because of, it may not be entirely clear. Now, this is really interesting. So again, all of these discussions have tensions. They demonstrate and illustrate the really positive advantages of being multilingual, but also some of the more problematic ones which point to institutional tensions. So, for example, this participant was saying, actually, she worked in a place where they had English only on the staff room door. Now, I don't know how long ago this was, and it seems to me quite problematic to put this kind of signage up, but this person felt that, people didn't like listening to her speak a different language with colleagues who also spoke the same language. And she said, look, it's professional judgment. If I'm speaking to a woman, you have to trust I'm a registered health professional. You have to trust that I'm going to have a professional conversation in any language. Obviously, you would do it appropriately. So I think it's very childish, I think, to say you can only speak English in the corridor, you can only speak English in the break room. And I don't know how we culturally accept that. So kind of pointing to kind of linguicism, discrimination against somebody because of the languages they speak or are speaking. Privately, she wasn't talking about, she went on to say, this isn't, in the staff room, I wouldn't sit and whisper in another language when there were other people there. That would be really unprofessional. These are like private conversations between two individuals having a chat. Or when she was seen to speak another language to one of the women she was looking after. A perhaps slightly more sinister implication and consideration are more racially oriented. So one of the contributors made some very astute remarks. She's saying, look, as someone as brown and working in the workforce, I know I'm more likely to get picked up and criticised for my work if it's not 150%. This is reflected in the statistics. Because of me simply looking differently, I know I'm more likely to be referred to the NMC. I know I'm more likely to be disciplined. So the added stress of all that adds pressure, but also wanting to help. So, there's that duality and issues with that. Being pulled from your work to support someone else and knowing you're going to get criticised for not doing your work. So there were some real tensions there that this maternity professional really wanted to explore, because it's, not necessarily a visible skill, a visible form of labour, a little like emotional labour. It's not being seen, and therefore if it's not seen, it's not recognised as an additional skill you bring to your job. It's not accredited in any kind of financial way, in any kind of institutional way, and it's not compensated. But it also has this implication on your, consequences for your routine job that you do every day if you're constantly being pulled from pillar to post to interpret, and potentially suffering as a consequence. So I'm at a kind of impasse, really, and this is where I would really enjoy having a wider conversation with people who are here today, because I think these findings are really interesting, and they are, as a whole, we still conceive of the UK as a monolingual country? If we recognise it's a diverse country, and we know we're very attentive to health inequalities and health inequities, and although language is not a protected characteristic, it's often conflated with race or nationality, and that in itself makes it hard to unpick. We know that language is a social determinant of health. We know that it affects people's ability to understand information, to access information, if interpreters aren't provided, if there aren't multilingual professionals there to support them. But we know with linguistic support that people have a much better experience, improved outcomes, and if you can provide continuity of care, this is very much going to advance some of the health inequalities that become so transparent within diverse populations, especially as we've seen illustrated over the last couple of years. But for the multilingual workforce, there are personal considerations and legal considerations that need further thought. If we have a diverse national population or pockets of diversity, we do understand that some areas are going to be more ethnically, linguistically, culturally diverse than others. But if you have a diverse population and that reflected in the workforce, which we certainly do, then these are attributes that can actually really support some of the agendas to redress health inequalities. But without recognition of it, there are legal considerations and personal considerations for those multilingual professionals. So they have to think about whether or not they have, first of all, they have the level of support, they have the level of language needed to interpret or translate for somebody. So, they have to really reflect on their own competency in a language and their ability to translate or interpret in a different field. They have to think about legal considerations of doing so, but they also, I certainly get the feeling from observations and from feedback from the multilingual professionals who I talk to, that they are really aware of the benefits of a shared language. So looking for recognition really of how we move forward with actually utilising the skill set that we have. So this really first looks back to the institutions. There's a lot of money spent on interpretation and translation, and so there should be, okay, because everyone deserves to have a conversation with a health professional that they can understand, where they're able to ask questions. But there are, institutions may be missing a trick, that they have also an additional resource within their workforce that can actually support their patients and people accessing antenatal care. So within that, they need to maybe tighten up legal frameworks and support mechanisms for multilingual workforces, which actually may enable other multilinguals who are hesitant about using their language at work because they're not sure of the financial implications, they're not sure of the kind of employment implications of doing that, and maybe some form of accreditation of proficiency, which enables people to practice legitimately and be rewarded for their skills. That's it. I'm just realizing I've talked for quite a long time. So I'd really like to open up the floor to any questions you may have about any part of what I've said today. I'm sorry, I started off very nervously, but yeah, I'd really, really welcome some questions or comments.
Thank you so much. That was absolutely fascinating. So just to reiterate, everyone, you can put your questions in the chat or into the Q&A button in Zoom. I'd like to ask a question, if that's all right.
Yes, of course.
So I was interested in the interactions. So a few of the interactions you mentioned in your slides, there was the patient, a husband, a consultant, and an interpreter. So I was just wondering if there was anything that you'd noticed in terms of response from the interpreters when you have a multilingual healthcare professional who is involved and starts interacting in a different language with an interpreter present. I know it's not quite directly related to what you're saying, but it was just something that struck me as interesting while you were talking.
Well, it didn't seem to be an unusual situation. They seemed to just be like, yeah, we'll just have, it seemed to be a huge amount of coordination of support, a real scaffolding for wanting to, for helping the woman understand information.
Mm-hmm.
And it didn't seem to be a competition or any clash or anything like that. There were other examples, which I haven't shared, of interpreters turning to patient companions and saying, do you know what that is in our language? I'm not sure I understand. And actually, which was really, in a way, kind of refreshing, because nobody can do everything, but then it was also a little alarming, because you think, this is really, the question she was asking, this other example, was really quite simple. You're like, you don't know what chickenpox is, you know. So I saw it as a kind of cooperative collaboration, collaborative efforts, kind of like all hands on deck. Let's roll up our sleeves. Let's see how we can, you know, make this really clear. They're not competitive, but I obviously don't know. It wasn't possible to talk to the interpreters. This is something I really regret. I spoke to one interpreter who I knew on a kind of individual level, and I didn't see her actually interacting with any patients. But I would really have liked to talk to the interpreters. Unfortunately, because of the time constraints, they, you know, rushing between appointments. I mean, the way that interpreters are employed and assessed is a completely different conversation. But I really felt like they were, you know, they come in, whiz out, and it wasn't actually possible to talk to them. But it would have been really, really interesting to find out their experience. Definitely.
Okay. All right. So we have a question in the Q&A. So our question is from Alexia. And our question is, in your opinion, how do you think time could be divided that didn't distract them from their actual job of taking care of patients' health? Referring back to the Polish nurse who was kind of taken away from her roles throughout the day.
Well, I think that's a really good question. I think almost every single conversation about interpreting and translation comes down to time, because we know that the consultations when you're interpreting, they double in time, and you know, and often people appear for appointments and they have their linguistic needs haven't been recognised, whatever reason, and they come without an interpreter. So there's always scrabbling around for either telephone interpretation or in this case, taking colleagues away from their everyday duties. In my opinion, I think it's just so multifaceted, but I do really believe that there is room to recognise multilingualism as a skill, and reward it with some kind of CPD, you know, recognise it in a CPD framework, award it financially, accredit people, so that you have somebody who perhaps is employed as a kind of, you know, 80%, I don't know, whatever your role might be, healthcare assistant, and 20% interpreter, something like that. But I think there's room for so many different ways of looking at this. There are hospitals in the States, for example, that employ departments of interpreters. But I think, you know, especially Spanish interpreters, because there are areas of the States which are almost bilingual, we know. But I think that with such diverse populations, so 100 languages spoken in the population I observed, you know, 300 languages in London or more, and some of them aren't written, some of them are just oral. I think it would be too complex to begin to look at it from that perspective. But I certainly think there's ways of recruiting bilingual staff to particular areas. So I spoke to an international recruiter who was, you know, recruiting generally for a specific area of healthcare, and that wasn't one of the criteria. And I thought, well, actually, that could be really interesting if you recruit, you know, if you've got a huge Polish-speaking population, you know, it could be an additional desirable criteria which could attract. I mean, I think there's a way of just moving out of that monolingual outlook to really seeing what's around us.
And you mentioned when you were speaking, you mentioned that the healthcare workforce will often reflect the population in that area. So if you have an area with a lot of, I think you mentioned perhaps Greek speakers, then the workforce can reflect that. So this isn't something that you, in your experience, is on recruiters' minds when they're looking for healthcare professionals.
I think the recruiter, I don't want to speak or misrepresent her. I'm not sure whether she was recruiting just for a local area or she was recruiting nationwide.
Mm.
So I don't want to misrepresent it, but I think it's something that certainly could be considered. You know, if you know the area that you're recruiting for, but I can't recall.
Sure.
Yeah,
no.
sorry.
Interesting. That's all right. All right. We have another question in the Q&A. So the question is, do you think that language limitation affects engagement of care in a dynamic way? Or do you think that physical care is adequate for them? Maybe too much importance is put on the language. There's lots of questions in there.
There are a lot.
So, yes.
I would say that language is core. I think it depends. It can obviously depend on the environment that you're talking about. For example, I'm sure working in something like dementia care, empathy and care can be, can be shown without necessarily using language. But at the same time, I think by not considering language, you're kind of disabling the patient, the woman, from being able to express themselves. So it's not necessarily about the carer, it's about that being patient-centered and thinking that they have the ability to ask a question, and that they're not, otherwise I think that, it's the power dynamic of the health professional deciding, well, what can I allow this, you're, without the language, you're preventing somebody from having any agency. And when it comes to things like informed consent, it doesn't matter how smiley you are and how lovely you are, you have got to make sure that people understand what they're committing themselves to or agreeing to, because otherwise we're contributing to more health inequalities. Does that answer the question?
Yes, I think so, yes. Yes. All right, so those are all of the questions that we've got today. Thank you so much for coming along today and sharing your research and sharing your experiences. It's been really, really fascinating and really interesting. Yeah, I think that brings our session to a close. All right, thank you everyone for coming along, and thank you for your questions, and thank you to Dr. Emma Brooks for taking part in our Ealthy professional development session this month. All right, so thank you, and I look forward to reading more and what you do next, Emma, and what's coming up.
Thank you.
All right,
that was really
thanks everyone.
Thank you.
All right, thank you everybody. Bye-bye.
Bye-bye.